So again, just megan.pass@memorial.org, and I can get that to you guys. So I check my email a lot, and so I can respond to you anytime you need an answer to that. So if you guys have any problems, so this section begins the material for the next exam. So this, you guys have an exam today?
Yeah.
You did. Okay. Sorry about that. So this begins the material for the next exam. There's 4 lectures on this one. So we have to figure out how we're going to break that down. I know we typically had 5 lectures with 10 questions from each lecture. So I don't know if we'll do more questions from each lecture or less questions overall. So I'll talk to Carl, the other course coordinator, on that, and we'll try to figure out what's best. So more questions, longer tests, so you get more of a chance to get more wrong and still do better. So I think that's probably what we'll do. But so anyway, we still have yet to figure that out, but that's in the works. So there'll be 4 lectures. I don't remember the last 2 where I think they're hypertension and arrhythmias are the 2 lectures that will be on the second half of the test. So germ, part 1 and part 2, and then hypertension and arrhythmias. Not really related, but so hopefully different material will help you study. All right, so please feel free to ask questions during lecture, after the lecture, during the break. We'll take a short break halfway through or so. This isn't really like a really long lecture by any means, so we should get you out of here at least an hour. But again, please ask questions. So today, as I said, we'll talk about contact dermatitis and then fungal and viral infections. And so starting off with contact dermatitis, don't read all this. We're going to go through the pathophys, therapy, special populations, and then patient education. So what is contact dermatitis? It's an altered skin reactivity caused by exposure to an external agent. And that's kind of an important part, is that it's the exposure, and that's where it gets its name, the contact dermatitis. So it's a combination of genetic and environmental factors. It can be single exposure or multiple exposures. And it accounts for over 5 million, almost 6 million visits to healthcare providers annually. It can be caused by irritants, so exposure to an agent that has a toxic effect on the skin, or it can be allergic. So it can be an exposure to something like an antigen that causes an immunologic response. So it can be further classified as like atopic dermatitis or eczema, so that can be in a form of allergic dermatitis. So the pathophys, so irritant contact dermatitis is not an allergic reaction. So this is damage to the water protein lipid matrix of the skin. And it causes an erythematous scaly eruption resulting from friction, chemical exposure, or thermal injury. And the severity depends on the exposure, what substance it was exposed to, the length of contact, the concentration of the substance, and the reaction appears only on the exposed skin. So if you're exposed in your arm, it's not going to appear on your head. So, contrastly, allergic contact dermatitis, like poison ivy, is an immunologically mediated response to an allergen. So there's an initial sensitization phase. So your first contact with that, you're immunized, and you can see a response in 5 to 7 days. And then you can have a re-exposure and a re-response from your immune system developing faster, because your immune system recognizes that antigen to that allergen, and it activates T cells, releases cytokines, chemokines, and cytotoxins, and that stimulates local blood vessels, recruits immune cells like macrophages and eosinophils, and amplifies the sensitization response. And there you get the immune response. In this, the reaction can spread beyond the affected area. So you may test the poison ivy with your arm, so you may see the rash over your entire arm and maybe on your chest as well. As far as like, you guys are probably like, oh my god, this is a lot of information. I'm not going to ask details as far as like allergic contact dermatitis is involved with the T cells, right? You know, that's not going to be on the test. So this is going to be more generalized questions. Don't don't worry about the specifics. A lot of this is for your information. I'll kind of highlight when I say like, this is really important sort of thing. So I'm not going to stand up here and be like, this is really important, but if I kind of, say something a couple of times and you kind of
Can you pass that along to the professor?
I haven't written the test yet for this section, so but I'm kind of like going through saying what's important and kind of I have a few notes on this as well. So. All right, so for atopic dermatitis, it's usually a pruritic chronic inflammatory condition and it affects a fairly large amount of the population, so 5 to 10%, a pretty large number of the population. It most often begins in childhood, and there might be a genetic component associated with this. There's some immunologic characteristics that are pretty common in this population, including high concentrations of serum IgE, decreased numbers of immune regulatory T cells, and defective antibody-dependent cellular toxicity, as well as cell-mediated immunity. There's a lot of autoimmune type things going on in this patient population, so why they get this atopic dermatitis. I didn't realize until I worked in the huge population that this is like such a huge thing, like all these kids coming in with this atopic dermatitis, but it really is like 5 to 10% of the population that they're going to be able to now. All right, so what is the best treatment for contact dermatitis? Prevention. So preventing contact with the offending agent is the best form of treatment, but obviously that's not always going to be preventable, especially with children running around outside. There are a lot of the allergies. Educating the patient on the causes, communicating them, and then for actual treatment, so that if you've gone beyond the preventative stages, then we need to determine the severity. So if it's a mild case, then a cool compress or colloidal oatmeal bath. So there's like packets of colloid oatmeal, I don't know why I can't say that word, treatment that you can use for the pruritus specifically. And then there's zero solution, which is just aluminum acetate. It's available over the counter that they can get to apply to dry vesicles and QA as well. And then if it's severe, then we can consider drug therapy. All right, so what sort of delivery vehicles should we use? There's a lot, like what's the difference between ointments, gels, creams, lotions? Like you just pick one, right? I feel like sometimes when orders come into the pharmacy, it's like, do you think about if it's a cream or an ointment, or you just pick the first one that's on the list? And so it is important which ones you use. So ointments and gels are the most potent and the most lubricating, and they're also the most diffusive. And so what does that mean? Like they're not going to let air through. When you put a layer of an ointment or a gel on, it's not going to be breathable. Creams are less greasy, but they can also be less effective, and they can cause skin drying. But they might be more desirable for the patient. It's going to be more comfortable than like lathering on an ointment. Like I'd rather put a cream on my arm than I would an ointment, because like if I put a shirt on, it's going to transfer less. It's going to be more comfortable for me, but as far as treating what I have, it's going to be less effective. So there's pros and cons to way. So lotions are just dilute creams. And then solutions, these are alcohol-based, and they're useful for treating things like the scalp. You don't want to put like a lotion in your hair unless you're putting it like on a scalp line, so you have to think about that as well. Spray products are useful for treating like a large area of the body. You have to think about dosing as well. So you say, oh, it's a 1% cream, but if you have this large area, these are still systemically absorbed. And so if you're putting half a tube of cream over half your body, you're still getting a lot of absorption. You're getting a lot of drug in the body as well. And so you got to think about that. So there are some of these topical products that are available as sprays that you can use to limit that systemic absorption and the systemic side effects as well. So moisturizers can increase skin hydration and improve damaged skin, and serve as a barrier. And they may be useful to prevent and treat irritant contact dermatitis. So again, another way to prevent contact dermatitis is to provide a barrier. If you can't provide a barrier with like a piece of clothing, you might be able to provide a barrier with like a cream or any sort of moisturizer. And then, as I alluded to, the barrier cream can be useful to prevent things such as diaper rash. So we use that a lot in our teen population, like different types of big diaper rashes that we or diaper creams that we can use to prevent diaper rash. What are the goals of drug therapy? We want to restore a normal epidermal barrier and then treat inflammation of the skin and control itching. Itching is a huge part, especially in children. And then if they itch it, they're going to cause the skin to break down and then further make that area worse because now you're taking away that barrier for the skin. The skin is a first layer of protection, and so now you can risk infection by removing that barrier. So first line of therapy for this is topical corticosteroids. And then second therapy could be immunosuppressive, systemic corticosteroids, or antihistamines. This is for overall drug therapy for contact dermatitis if we have to go with the drug therapy. So the mechanism of action for corticosteroids, there's a lot. And you don't have to remember all of the different mechanisms of action. I'm not going to ask you to list them or anything like that. But the main ones are to inhibit phospholipase A2, which is an inflammatory mediator, and then to cause local vasoconstriction. So topical corticosteroids are obviously safer than systemic steroid therapy because you don't get as much absorption, you get less distribution to the rest of your body. They're applied twice daily for a maximum of 2 weeks in adults. The dosing is different for children as far as duration. And then you want to avoid if a secondary infection is present. Tolerance may develop to these steroids, and so it's not recommended to use them prophylactically. If you don't want someone to be on the steroids, so say like once a day for, just to keep it at bay. You don't want someone to be on that prophylactically, so only when they need it. So topical corticosteroids are broken down into 7 different classes based on their potency. So the highest potency is class 1, lowest potency is class 7, and that's based on their vasoconstrictive properties. You don't have to know which ones are in which. I don't know which ones are in which. I don't care which ones are in which. So basically, like if you need a certain steroid, I'm not going to go to the chart. There's a chart on the next page for your information. I don't memorize this chart. I don't look at it for making a recommendation. It's based on what the treatment has. So this is again for your information. There's a link to where the chart was from, but this is not something that you need to memorize. You just look at it. So fluorinated agents are more potent, and so we want to avoid these on the face. And they may cause skin atrophy and steroidal rosacea. And so again, using them for the minimum period needed, up to 2 weeks in adults, and again for the shortest amount of time necessary. So occlusive dressings can be used, and so that's where you wrap the area in you could use like a plastic type thing, basically, so there's no air that can get into it. And so I don't see these a lot in practice. A lot of times we'll use like an ink bandage or something, or they can use like a Tegaderm type, not like a wrapping, but that would be more of just like a patch over the area. But depending on how, like if it's the entire leg, they might wrap it in like a plastic type thing, and then put like an ink bandage over it. So you wouldn't want to use an occlusive dressing with like a very high potency product, because then you think you'll increase the potency even further. And then you wouldn't want to leave these on for more than 12 hours, so this would be a routine change type thing. And then you would initially use it, you would just use it initially to kind of get the symptoms under control, and then after that you would use the occlusive dressing. Some adverse effects are listed here. The biggest ones are skin irritation.